at home. My name is Tessa de Vries. I'm a program maker at Studium Generale, the public platform for knowledge and reflection of the Utrecht University. And tonight we have a very interesting lecture by Dr. Megan Milota, and she is an associate professor of medical humanities at UMC Utrecht, and she advocates the importance of a more human approach in medicine. So instead of focusing on objective data, what doctors are often trained to do so, we have to take the personal experience, the social surroundings, and the stories of patients more into account, actually. And how and why we should do this, she will tell us in a minute. We are not organizing this evening alone. Our partners are the Bibliotheek Utrecht, where we are at this very moment. Also the Inscience festival, Nijmegen, and the Integrity Thursdays of the Ethic Institute of Utrecht University. And after the lecture, there is room for discussion with you here at the Bibliotheek Utrecht, but also with you watching from home. So please type your questions in our live chat, and my colleague is here. She will make sure I get them as well, and I will be able to ask them Megan. Also for the people here in the audience, please stay seated after the Q&A, because we will screen the documentary Hunting for Hedonia. And that's a very nice extension of the lecture, so please stay. And for now, a very warm welcome for Dr. Megan Milota.
Thank you. Yeah. So today is Thanksgiving. I'm sure you've all heard that in the media everywhere, mostly because tomorrow's Black Friday. It's been Black Friday for weeks here, it seems. I just want to say I'm really thankful. And we always say that on Thanksgiving. Why are we thankful? I'm really thankful that we can be here together. And I'm thankful for the people who are watching online, but I'm really glad that we can be in these seats and talk to each other, and afterwards that you all have the opportunity to watch a really wonderful documentary film. I'm going to talk to you today indeed about the doctor-patient relationship, how I envision it, and how I think that we can improve the doctor-patient relationship, clinical interactions, by using the arts. So I want to start with some questions. Obviously, the people who are watching via their computers can raise their hands, but I can't see them. So I'm looking at the people here in front of me. How many of you have ever been ill? How many of you have ever been ill for more than 2 or 3 weeks? How many of you have ever cared for somebody else who's ill, who's been ill? And how many of you have had an unsatisfying conversation with a healthcare professional? Something that left you wanting more, maybe a little upset, frustrated. Yeah. So obviously those of you watching from home can't see it, but for almost every one of those questions, everybody's hand was in the air. The point I'm trying to make is that at some point in our lives, we're all going to be sick, or we're going to care for people that are sick. And that means that we're going to have to interact with healthcare professionals, be that doctors, nurses, tertiary care professionals, dentists even. We're going to have conversations about how we're feeling. Now, if you think about it in English, in absolutely almost every language, how many words do we have to talk about pain? I'm in pain. It hurts. I don't feel good. But when you expand those small amount of words, you can count them on 2 hands. When you expand them to include metaphoric language, the possibilities are endless. I have here 2 examples from a collaborative work by Deborah Padfield. This is from 2003. Deborah Padfield is an artist and sufferer from chronic pain. She went to a clinic in Great Britain and she interviewed a series of chronic pain sufferers. And together they made artwork, because they found that the words that they had to express what they were going through just weren't enough. So by using photography and mixed media sources, they were able to, like I said, expand the metaphoric language for pain. Now, I tried to use these with my medical students at the University Medical Center in Utrecht, and I asked them the following question. What is this person suffering from? And I give them about 30 seconds to answer, and I've written down a couple of their answers for you this evening. I get things like nerve damage, MS, depression, something psychosomatic. The point is that there's a wide variety of interpretations when you open up from those 5, 6 words that we have to describe pain. And that's exactly what I want my students to see, that pain is a subjective experience and that the description of pain is also an interactive process. That I need to be able to listen to you tell me or explain to me or write to me or express to me with your face what you're going through to be able to help you. I have another example. This one flummoxes them. They get really frustrated with this one. What is this? When I look at this image, I see a face, a distorted face. I see a repetition 3 times of a mouth, a smile or a grimace. It's not very clear. To me, it looks like a grandfather clock. I see images or little bits of a clock and they're broken. That's what I see. When I ask my students to diagnose this person, they say things, again, like nerve damage, MS, depression, something psychosomatic. And actually, if you read the story that accompanies this picture, just like all of the pictures that are included in Deborah Patsfield's work, this person worked for the train company. Time was incredibly important to his job, being on time, making sure the trains ran on time. And when he broke his back and was no longer able to work or move without pain, his life fell apart like a watch that falls on the ground. And he couldn't put it back together again. So to me, an image like this is vastly more meaningful than saying, I broke my back, I can't work. And that's what I want my students at the medical center to see, that pain and suffering and illness isn't just what you see in a dossier, a reduction, something that can feel like it's taking away your autonomy, but it's something that's part of a lived experience, a narrative that's ongoing, that's changing with every day. The image I have here now is from Rachel Lindsay's graphic memoir, RX. It's about her own coping with bipolar disorder, and this is about an involuntary hospitalization. So as you can see here, the person, the being, is being held by a greater force that's outside of the frame. This person is very upset and very angry and is trying to fight and get away. But unfortunately, this person is thrown or dropped into a dossier. You can call it the effacing of the individual. This is obviously what we don't want to happen. I have a quiz for you. What I hear quite commonly amongst medical professionals, both students and people who have been working a long time in the clinic, is the following. There's just not enough time to talk to patients. I have to see a new patient every 5 minutes, and I have to do it all day long, and I have to do all the write-ups afterwards and all the clinicals, and I have to do so many other things. I just don't have the time. So I will counter that with the following study and the following question. How long does it take the average patient in the United States to speak at the beginning of a consultation before being interrupted? This is a study that was conducted with outpatient clinics. Anybody want to make a guess? 20 seconds. Oh, such a pessimist. Is there anybody that wants to offer another one? 3 minutes. Okay, so we see 2 sides of the spectrum here. 20 seconds, 3 minutes. The average is 22 seconds. Yeah. Okay, now here's the next question. How long does a patient spontaneously speak when uninterrupted? So if you let a patient say everything they want to say, on average, how long does that take? An hour. Okay, anybody else? Yeah. 1 minute. Well, again, 2 sides of the spectrum here. The answer is 92 seconds, 1.5 minutes. Obviously, there's people that need an hour, or a couple of days, or a week, or a year. And there's people that can tell their story in 1 or 2 or 3 sentences. But the average is 1.5 minutes. So this idea that we just don't have time to listen is, in the majority of cases, a fallacy. I say this because I think it's really important to think about what this implication is, that we need to talk to each other, that's the most important part, in my opinion, of a clinical interaction. Obviously, we need to come up with a diagnosis and a treatment plan, but that all begins with the anamnesia. That's telling your story, what's going on, what you need help with. And what I want to paint a picture with today is based on 3 questions that I want to pose. I don't really have an answer for them, but I think that's the overcoupling theme that I have envisioned this evening, and it's also a link to the movie you're going to watch after this. So these are my questions. What skills do medical professionals need now and in the future? How can we prepare them for a career in healthcare where technology will play an increasingly prominent role in clinical interactions? And what skills or qualities are uniquely and irrevocably human? I ask this because we're living in an age where there's an accelerated and an astounding increase in technological advancements. And I say this without any hint of irony. The things we're able to do now, we couldn't even envision 5, 10, 20 years ago. And we can't envision what we're going to be doing in 5, 10, 20 years. The horizon is approaching us so quickly. So in radiology, for instance, we're already using artificial intelligence applications to help with diagnosing patients. It's just standard part of a lot of different departments, including the one at the University Center in Utrecht. This is something that may happen in other departments. In most departments in large university hospitals, we work almost exclusively digitally. So for instance, in the pathology department, we're not looking with microscopes anymore, we're looking on screens at tissue samples. These things are going so fast. So the question is, again, what qualities do we have as humans? What makes us irreplaceable by all these technologies that we have? What kind of skills do we need now? What kind of skills do we need in the future? And a disclaimer, I'm not trying to imply that we're not doing a good job, but that the medical professionals aren't doing their work well. On the opposite, exactly. I'm just saying that maybe we need to help enrich or improve the education in a way that we can ask these questions and come up with meaningful answers. So the real question is, what kind of relationship do we want to have now with our medical professionals? What kind of relationship do we want as citizens, as people who will be ill, maybe are ill, are caring for people who are ill? Now, Howard Brody has a really great answer to this. He says that we should work more on co-constructing narratives. He's got a wonderful title to his article. I had to include it. My story is broken. Can you help me fix it? He says. So he says the part of the doctor is not just to diagnose and to treat. The critical portion of any clinical encounter is telling narratives together, the co-creation of an illness narrative. That's a healing power and a healing element of any encounter. So what he says is that a physician should approach the story of a patient's illness in a way that encourages the ultimate goal of shared power making. The power of making the patient a more active participant in his medical care. And we have plenty of studies that have shown this, that if you have empower patients to feel like they're actively playing a role in deciding what's happening in their care and treatment, that they have more therapy compliance and that they feel generally better. So yeah, it's not just having fun and talking all those nice words that we like to teach our students about shared decision making and patient-centeredness. It actually has an impact on the well-being of the people who we want to treat. Now, one of my mentors and idols, I'll say, Dr. Rita Sharon, she's an internist in the United States and also a doctor in comparative literature, was working at Columbia University in the 90s, and she thought, oh man, this medical education, it's fantastic, but there's one thing we're missing, and that's this ambiguous skill. We call it empathy. How do you teach empathy? How do you make doctors more empathic? And her idea is that we do this by teaching them literary practices, by making them read books. And this is her statement. I love this one. Because they become good readers, they become good doctors. Now, when I say this to my students, they laugh. Yeah, reading books. We're not here to read books. We're here to learn about the body and diagnose and treat and make people better. But I would argue, yeah, we're also here to read books and watch movies and read poetry and maybe watch some Netflix series. My idea being that when you encounter a fictional world in Netflix, let's use that as an example, something different happens than when you read a case report. When you're reading a case report that's very dry, a summation of symptoms and patient history, you're reading it for a specific purpose. That's to diagnose, to learn something, maybe to get a good grade. But when you're watching a Netflix series, you're doing it for a different reason. Why do we watch a Netflix series? Why do we watch movies? Why are we here tonight? You want to tell me? Yeah. Yeah. We want stories about people other than ourselves, right? We want to explore. We want release. We want an escape. We want to relax. We want pleasure. We're curious. And because of those are different intentions. And because of those intentions, we have different feelings. And maybe we allow ourselves to have different feelings. So I ask this to my medical students too. How many of you have cried when reading a case report? Nobody raises their hand. Although there's certainly very sad things that you see and read in case reports. But then I ask, how many of you have ever cried when reading a book or watching a Netflix series? And more than half the room raises their hands, which I find rather good. I'm sure more people have, but not everybody dares to say it. When you encounter a fictional world, that's my belief in what I've noticed with my students, that you have a different encounter with another. You gain experiences or knowledge about others' individual experiences, and you also gain more knowledge about yourself. That's what I'm trying to teach my medical students. We don't just watch movies and read poems. We also talk about what it does to us. The idea is that you grow in self-knowledge. You grow in self-reflective capabilities, and those are all things that can help you be more empathic later as a doctor. So I see it as my job is to create this giant bucket of experiences, of patient stories, of narratives, of other people other than ourselves. And during their medical training, I want to throw as many things into that bucket. Because my hope is that when they're actually sitting in the clinic and talking to their patients, they think, oh yeah, that reminds me of this. And I think that if they recall a fictional narrative or a case report, it doesn't matter so much. But my belief is that with a fictional narrative, there will be emotions, this memory of emotions that they had when they were reading or watching, and that maybe that'll be more vivid. And for that reason, maybe they'll attune their care in a better way to the person that's sitting in front of them. I think it's really important, and this is the question I asked about, what do we have, what makes us uniquely human? Because as I said, the advancements technologically are going so fast, we almost can't keep control of it anymore. We used to think, yeah, algorithms, they can do a lot of things. They're useful for us. They're machines. They're workhorses. They're great for counting stuff that we don't want to do. They take over the work that we don't want to do, but they'll never be intuitive. They'll never be storytellers. They'll never be able to replicate the cadence of speech or the impromptu thought and associations that we in our human brains can. I have for you a citation. I'm going to go ahead and spoil it and tell you that an algorithm wrote it. It's a passage about creativity. So an algorithm was asked to write about creativity, and this is what the algorithm said. I think creative expression is a natural byproduct of growing up in a diverse world. The more diverse the world is, the more you get exposed to different people, to different opportunities, to different places, to different challenges. And the more diverse that is, the more likely you'll be to be able to put the dots together and to form something new. Now, this computer wasn't just any computer, this algorithm. This is an algorithm called GPT-3. It was developed by a think tank in Silicon Valley, and they trained it on Twitter feeds, Facebook, all of Wikipedia, books, films, people's books, famous people alive and dead. And for instance, they trained it on the following person, Scott Barry Kaufman. He's a psychologist. He's very active on Twitter and posts a lot on blogs. And they asked the computer, the algorithm, to write about creativity in the voice of Scott Barry Kaufman. It was so effective that it scared the crap out of him. So here's his tweet. Crazy accurate AI. I'm impressed. That's definitely something I would say. Did you develop this program? He was kind of scared. So he asked to talk to this algorithm. They had a conversation. It turns out when you train an algorithm on all Twitter feeds in existence, it can be rather volatile and answer rather angrily and abruptly and unpredictably. So the conversation didn't go very well. That was a relief to Scott Barry Kaufman. But it means, at this point, a computer can't think and act intuitively like we can, but it's getting pretty close. So once again, what are the qualities that are irrevocably human? What do we need in the future to have conversations with patients or as patients with our healthcare providers? There's a lot of things that we can do. I'm going to end here with some practical things that we do, kind of give you some hope and some thoughts for the future. And I want to end with a few quotes out of the movie. But here's a few examples. You can use the arts to help teach doctors about the experience of patients. This is Maartje Nevian's documentary film, Ik ben er even niet, part of a bigger project called If You're Not There, Where Are You?, where she took children suffering from petit mal epilepsy and she paired them up with artists, because her own experience, having suffered from it, was that when you're not there, when you're having an epileptic fit, you are experiencing things. And science said, no, nothing's happening during an epileptic fit. We can't see anything on the screens. Your brain is essentially not doing anything. So she gathered a bunch of patients together. They worked with musicians, artists, and they made the most beautiful things to try to describe what actually was happening in their brains when everybody said they weren't there. So this changed the medical profession, actually. The neurologists that were looking at this and saw the film and worked together were just astounded by the fact that these experiences were happening. Another example, like I said, we should all be very scared of algorithms. No, not really. We should look at how algorithms are being used currently. We have a project going right now where we're interviewing radiologists and pathologists, asking them their stories. How do they make sense of what's happening, this digital transition? How do they envision their work now and in the future? What do they see as possibilities? What are their fears? What are the ethical considerations that they think are coming into play or will come into play in the future with these digital workspaces and these algorithmic tools? I don't know if anybody knows this, the Verhalenbank Psychiatrie, story bank for psychiatry. This is where patients can donate their stories about their experiences in the Netherlands with the psychiatric facilities that we provide. Those stories are published online and meant as a source of solace and help, and they're also used for research to improve care. The New Utrecht School, I'm part of that. We organize interdisciplinary public dialogues with artists and doctors and patients talking about the healthcare profession. We organize summer schools, and we've also developed a minor in medical humanities, and we're developing a master in medical humanities. So we're trying to get people to talk together, not just doctors amongst each other, but also people from the humanities to talk with doctors and doctors in training. The idea being that cross-pollination is going to lead to better outcomes regardless of the field. And now some examples, what I do with my medical students. I already showed you a couple of images. I like to work with images a lot of times with artwork. It's a lot easier, but I also teach them closed reading skills, so we do read poetry and stories together. When I show them this image, this is from Roman Vishniak's A Vanished World, I ask them to write a minimal story. So first I teach them what a minimal story is, what are the elements of a minimal story, what do you need in a plot, and then I teach them the typology of illness narratives, according to Dr. Arthur Frank, who's a cancer survivor and writer of The Wounded Storyteller. I say, okay, most stories are told in one of three ways: a chaos story, a restitution story, or a journey story. And I ask them to write a minimal story about this person, this little girl, using one of those three typologies. The idea being that when you experience it, when you practice yourself, telling a story about being ill in the first person perspective, that you're also practicing that empathic skill. You're taking on the perspective of someone else. You're learning about others' experiences. We also do backward, sideways, forward context storing. Like an example is that I give them a clinical case study of a child born prematurely, taken to the NICU, and because of the dire situation that the child is in, that the staff do not want to resuscitate the child. The parents don't agree, out of belief. And I have them retell the case study from one of the following perspectives: the parents, the NICU nurses, the chief pediatrician, the ambulance driver that took the baby to the hospital, the midwife that delivered the baby at home, or the judge who has to decide whether or not this child should be resuscitated. And what you notice is when they take these different perspectives and they tell the stories again and again from each of these perspectives to each other, that something happens. They gain a deeper knowledge. And they're also practicing their creative skills. Story clinics. I have humanities scholars together with doctors in training interview patients. They have to be silent for a half hour while somebody tells a story. Then they each get a turn to tell what they heard. They hear very different things. And then in dialogue with the patient, they create a narrative together. And they go home in the humanities scholar and the doctor in training. They write the story up. They send it to the patient. The patient sends it back with improvements, suggestions. So this is a practicing in that co-creating narratives. The idea being the more they do this, the more ready they'll be to able they'll be to do this in the praktijk when they're working. I have one example of feedback from one of the students, what it did with this person. The patient told, the final assignment really let us see how important it is to see someone as more than just his illness. The patient told us this when they gave us feedback at the end of the story clinic. For instance, he said we could have asked about his prognosis, or we could have asked what he meant when he said that he was walking around with a sword of Damocles hanging above his head, or how it felt to attend the funeral of his fellow patients. The idea being here is that our medical professionals need to learn to ask the right questions. You could say that's the essence of what I try to do at the University Medical Center, and the essential answer to the questions I'm asking. What is irrevocably human? That's the ability to ask the right questions at the right time. I don't expect you to know what this is. This is Old German. Ochem was vieret dir. If anybody knows what this is from, I will bow now. Anybody know? All right. It's from Parzival. Does anybody know Parzival? It's a Grail story. This is a 13th century text in a 14th century illuminated script. So the Parzival story is a Grail story, right? So Parzival's out looking for the Grail, and he runs into this king. His name's Amfortas, and he's very sick. He's also called the Fisher King. And he's been told beforehand, when you meet Amfortas, the way to save Amfortas is to ask him the following question, Ohim was vieret dir? Or, uncle, what ails you? Or, sir, what do you suffer from? Now, Parzival has been trained never to ask unnecessary questions. He's had a bad education. So he gets to the castle. He could see the king suffering very badly, and he doesn't dare to ask the question. And when he wakes up, the king is gone, and the land is barren. And it takes him 30 years to find the king again. The point of the story being, you have to ask the right question at the right time. And I think that's our job as educators, and that's our job as citizens here, is to ask the right questions as well. It's not just the doctor's job to ask the right questions to us. We also need to think about what's the right question that we want to ask our medical professionals. What do we want to ask each other? What kind of conversations do we want to have with each other about medical care? Again, more and more technology, more and more possibilities. We need to be asking ourselves, what's quality of life for me? What's bearable? What's not? Where do I want to spend the last days or weeks of my life? Who do I want to be around me? And what do I consider necessary care, essential care? This brings me to the documentary. I have 3 stills from the documentary, and then I want to take some questions from you and then let you watch it. There's so much to talk about. But this is what intrigued me. There were some great questions at the end, and that's a link to what I've been saying so far, and I think a link in other ways to the greater themes of the film. I'll go ahead and spoil this. It's narrated by Tilda Swinton, so my voice is much less pretty, but I'll say it anyway. We have entered a new landscape with great promises and tempting horizons, but we're also in unknown territory. How do we steer our course into the future? As we steer our course together into the future, I think these are questions we need to ask ourselves. What kind of technology do we want? What kind of consent do we want to give for the use of these technologies? What kind of interactions do we envision with our medical professionals, with our loved ones, with the people we care for and who care for us? And I'd like to end with what I think is the most beautiful image of what the doctor-patient relationship is or should be. It's from Sebastião Salgado's work, Genesis. What I see here, and you're welcome to see something different, that's the whole point of metaphoric images, is that they can be interpreted so many ways. I see 2 people. It's misty. There's a sun, maybe the moon. I could just see the banks on the other side. There's other people too. These people, are they working together, going in one direction? Or are their backs turned to each other? Are they fighting for different things? Do they want to reach the shore together? And what's to be found there? Again, these are all questions we can ask ourselves the next time we visit our doctors, or hopefully later tonight on the bike ride home. That's what I wanted to tell you today. Obviously, I don't have any answers to the questions I posed, but I hope that that gives you some food for thought in the next days or weeks or next couple minutes. And I thank you for your attention.
Thank you, Megan. If you're watching from home and you still have a question, please type it in the live chat because you can still send it to me. I'm just very curious because you showed us two artworks in the beginning. Do you show them again at the end of your whole lecture? You're giving a lecture.
Yeah, I show that too during what we call a werkcollege, where we're talking about, theoretically, about shared decision making and patient-centeredness. And I use this to sort of challenge their, they all like to talk about shared decision making. They've learned about it in their communication training since their first year of medical school. But then I try to, take a different side and ask them what they think, those images are. And then they realize that even with these notions of shared decision making, they still have very different ideas about what a certain person is actually suffering from. No, I don't show it to them at the end of 6 weeks. That'd be a great idea to do. Maybe at the end of 6 years of training and see what they say then.
It would be interesting what they have to say. And if it's still somebody suffering from, what was it, nerve damage?
Yeah. I think it's more the idea that there are so many interpretations, and their notion of what they think they're seeing is also based on what they've experienced before. So I think they need to realize that even their own reasoning skills are subjective and are based on their own habitus.
So we have around 15 minutes for a Q&A, so I want to go into the audience. Is there anybody who has a question for Megan? Not yet. Yes, one.
Can I just, without the microphone?
Yeah, I will repeat. Yeah.
My question is, as a patient, I usually try to reach the doctor, right? So I try to be critical about the way the doctor thinks. And I first do it in a technical way because I have a medical biology background. Are the students also trained in being confronted with personal questions? Because I think that's where it starts. If you want to ask the right question, I think you have to be close to yourself, dare to ask the question, what's ailing you, for example?
Yeah.
I think it takes a lot of courage.
Yeah.
So how are they trained in, are there role plays, or how are they trained in that? Are they trained in that?
In opening themselves up, you mean? They're they get a lot of communication training. So I don't want to give the impression that they're. Oh yeah, are the medical practitioners, the medical students, also being trained to open themselves up, to also be asked challenging questions by their patients about themselves, personal questions maybe, or to turn the question around to the question asker and say, how are you? They do a lot of acting things with actors, but it's always with that professional stance, right? That you're here to diagnose and you're there to help and you're there to come up with the solutions. So what I do in my courses, I have an elective course, Narratives in Medicine, in all of the narrative medicine things I do from the first year into the 6th, is that I try to get them to think critically, to reflect. And that's exactly what I want. I want them to think about themselves in those situations and how they think and feel. And that's challenging. And it's hard, but I think it's something that they need to be doing more. Yeah.
And how do you get them on board? Because it's challenging. You mentioned it already a couple of times.
Yeah.
Also your colleagues. How do you get them with you in this whole?
Well, I try to do narrative medicine with them. My most successful text is called Brute by Richard Seltzer. He is a physician. He passed away 2 years ago, and also a writer. So he writes this short story called Brute. It's about a late night in New York City. He's the only one on the floor. We don't know if it's him or some fictional version of him. And a patient comes in, an African-American man, and nobody's helping him. And he does something absolutely horrendous to this man in order to be able to stitch a large wound on his forehead. it's a story that you can't read without gasping at a certain moment. And what I like to do with my colleagues who think, I don't know if I need this, is I read that short story with them. And with my students, it's the first short story I'd read with them, because then I have them on board, because they feel something, and they think something, and they have an opinion. And then 10 minutes later, they realize, oh yeah, that was a really great discussion. And that usually brings them on board for the other things too.
Are there other questions from the audience here? No, I have some questions from people who are watching from at the live stream.
Great.
Let's open the phone up. So Malou asks, how do you feel about doctors becoming too emotionally involved when allowing themselves to really get to know the personal stories of patients? Isn't it trying to stay objective and maintaining a distance from the patient also a form of self-protection?
Yeah, that's a great question. That links to the question you were asking too, I think. What is the right amount of empathy? What is empathy exactly? And can you practice empathy every 5 minutes with every single patient you see? Isn't that asking too much? I think that's a really personal question that changes per person, and that's what you have to experience when you're actually working as a clinician. Is what kind of relationship do you want to build? What is something that you can continue to do, that you can be able to bike home at the end of the day and make dinner and hug your kids without being devastated? And I think I'm not asking that you cry with every patient. That's not reasonable. I think it's just finding the right attitude and listening with empathy. What we call it is bearing witness to stories of the self. That you open yourself up for those few minutes to the world of somebody else. That doesn't mean that you have to like take that person into your heart and carry them with you your thoughts to bed. But that moment that you're being there and you're being present and you're allowing that person to tell the story they need to tell. I think that's a little bit different.
Yeah, but do you also teach students to how to set these borders, to just not open too much to the patients?
Not in my classes, no, but they do get that in their communication training, is like learning different ways of communicating with patients. Yeah.
Bas Wilders asks, it's all about empathy, but how do you improve that?
Yeah, that's one of those chicken and egg questions. I don't know. Yeah, I was just at a conference last week where they said that empathy is absolutely unmeasurable. And I have to say I kind of agree with that. Empathy is like this catch-all term that we have for referring to this feeling of being with someone. And that moment where you're not judging someone, but you're accepting them for who they are and what they have to say. Yeah, so the question again was, how do you, I got my little side thing. How do you improve it? I think you improve it, like I said, by increasing that bucket of experience that's not your own. I feel that is intrinsically linked to what we call empathy, is being able to understand that there's so many experiences other than yours, and that you'll never be able to have the experience of others, or even compare your experiences to that of others. So building up that bucket of experience, I think, is important.
That helps.
Yeah.
Another question from online is from Miesje Bouwman, and she asks, do you use any of the short stories of Salinger for educating students' empathy?
Yeah, that's the first story I use in my elective course, Narratives in Medicine. It's A Good Day for a Banana Fish by Salinger. It's a story where the main character, who you learn about in a lot of his other stories, abruptly commits suicide at the end of the story. So we talk about, the structure of the story and what makes it so surprising that happens. So we do what we call a closed reading, is where we're looking at how a story is created to evoke a certain mood. So why would you use a certain teller? Why would you have certain repetitions? Why would you build the plot up in a certain way? And what is the impact that it has on the reader? So this idea is that if you use those literary practices, that you come to a deeper understanding of the profundity of the work. Yeah.
Questions from the audience?
Mm-hmm.
Shared language, which is very often used by psychological professionals, of course. Do you use any of that experience in classes?
So I'm going to repeat it, because otherwise our people at home cannot hear it. Do you use any psychological knowledge in creating stories?
Yeah, that is an option, and absolutely. So I know at Columbia University, they have courses on that as well. I'm a comparative literature scholar, and my background before that was in law. So I tend to stick to my field of expertise, which is, post-classical narrative theory. But yeah, that's absolutely an option. That's the great thing about this type of medical education tool, this didactic tool, is that you have this the structure is, the encounter with the narrative world, and then thinking about what it does with you, writing about it, and then discussing it. So you can use all different kinds of tools to talk about what it does with you and why it does that to you. Yeah.
Other questions? I think we have room for one more because it's almost 8:45. Then I'm just very curious. How do you? You're not with many in this field, I think.
Mm-mm.
How did you came across this whole? How do you say it in English? I'm trying to find the words. But how do you became so interested in narratives and medicine?
Good question. Well, I started, my dissertation was on religious narratives. So how do we talk about belief in the United States? Because 90% of Americans believe in the metaphysical. So I thought, a great way to talk about belief is to talk about belief through the filter of novels. So I did a qualitative analysis of book clubs throughout the United States and read thousands and thousands of online reviews. And while I was doing that, I got interested in narrative ethics. And when you get interested in narrative ethics, that's a subfield. And then very quickly, you learn about people like Rita Sharon and her team that works with medical practitioners. So when I was doing my PhD, I was also studying at Columbia, because as soon as I learned about the narrative medicine program, I thought, this is for me. So yeah, it's sort of by chance. But just a general interest in how fiction or the arts can help us think about our own ethos, what we believe and what we believe is good, and what we believe in, yeah.
One final question, or are we all good? Yeah. Thank you very much. In about 15 minutes, we will screen Hunting for Hedonia. Also, thank you for the audience back at home. If you want to see more lectures like this, go to our website, sg.uu.nl, or you can click here. Now you can't understand me here. Thank you very much. Have a nice evening, and see you next time.
Bye.